Lecture 2 of the Gallbladder and Biliary System. This is Chapter 10 of Hagen Answered, and we'll be talking about pathology. The common pathologies we're going to cover today include sludge, cholecystitis in a variety of forms, torsion, cholelithiasis, porcelain gallbladder, hyperplastic cholecystosis, gallbladder carcinoma. Signs and symptoms of gallbladder disease are going to include nausea and vomiting, loss of appetite, right upper quadrant pain that may radiate to the right shoulder blade, jaundice, elevated bilirubin, dark urine, clay-colored stools, fatigue, and fever. Sludge occurs from biostasis. This can be caused by biliary obstruction, prolonged fasting, alimentary nutrition, or IV use. So anytime there's an obstruction or stasis, you may see sludge. Complications of sludge include acalculous cholecystitis, the forming of stones or cholelithiasis, and findings are going to be echogenic debris within the gallbladder. It can be a fluid on fluid level like you're seeing in these ones here, because sludge is gravity dependent, so it's going to settle towards the bottommost part of the gallbladder. You can have sludge with or without stone formation, or you can have tumefactive sludge. Tumefactive sludge is resembling a tumor, and it basically means that it's going to get compacted or balled up. Okay, so it forms sort of a mass in there. Cholecystitis comes in many forms. We're going to talk about each one briefly. There's acute cholecystitis, emphysematous cholecystitis, gangrenous, acalculous, meaning in the absence of stones, and chronic cholecystitis. Sonographically, what you're going to see is a gallbladder wall with greater than 3 millimeters of thickness. You may see a distended gallbladder lumen, larger than 4 centimeters. There could be gallstones in there, so they can have cholecystitis with or without cholelithiasis. Oftentimes, cholecystitis is caused by an impacted stone, and the place where you might see that stone is going to be Hartmann's pouch or the cystic duct or in the neck of the gallbladder. They're going to have a positive Murphy sign. This is pain above the gallbladder when you press on it, and it tends to be called inspiratory arrest, because when they're starting to take in that breath and you push, their breath kind of catches. Okay, and then increased color Doppler flow. We're looking for hyperemic walls. We want to put color Doppler on the gallbladder and look for hyperemia. You may see edematous walls as well, or you may see fluid collections outside of the gallbladder, surrounding the gallbladder. This is called pericholecystic fluid. So here we have a case of acute cholecystitis where we can't see any stones, but we do see that the wall is thick. There's edema around the gallbladder. And then notice right here we got a little bit of anechoic area kind of going down this way. And we got a little anechoic space here. That is pericholecystic fluid. Here we have acute cholecystitis in the presence of tumefactive sludge. You can see that there is a fluid on fluid level up here, but the sludge appears to have started to kind of combine and stick to itself. When you roll this patient, you may see that this sludge rolls as a unit as well. That would be tumefactive sludge. So here we just have some more sonographic appearances of cholecystitis. This first one, we can see the gallbladder doesn't look terrible. It's a little bit thick around the walls, and we do have some pericholecystic fluid. Now here we have what's probably a gallbladder with necrosis. This is most likely a gangrenous gallbladder. And then we've got a severely edematous gallbladder over here as well. Notice the ascites surrounding the gallbladder. We've gone past pericholecystic fluid and into ascites here. This may be secondary to liver problems. So emphysematous gallbladder is a rare complication of acute cholecystitis. It's rapidly progressive and it's fatal in about 15% of patients. It's going to affect more men than women, and about half the patients are going to be diabetic. Gallstones are also not present in 30 to 50% of the patients, meaning we can see acalculous cholecystitis progress to emphysematous gallbladder. It's associated with gas-forming bacteria in the gallbladder wall and the lumen with extension into the biliary ducts. If you'll recall, we talked about air causes dirty shadows. So you may see dirty shadowing or you may see comet tail artifact in an emphysematous gallbladder. The particular concern is gangrene is with associated perforation is a complication for emphysematous gallbladder. If you see an emphysematous gallbladder, it's a surgical emergency. You don't want your patient to leave until you've spoken with the physician. How it looks on ultrasound is going to be dependent upon the amount of gas that is within the wall of the gallbladder. You'll see a prominent bright echo along the anterior wall, and you should see ring down or comet tail artifact directly posterior to that echogenic structure. It can appear as a packed bag or a Wes sign with a curvilinear echogenic area and complete posterior fuzzy shadowing. Remember, that fuzzy shadowing is going to be that dirty shadow that we've talked about. A Wes sign is wall echo shadow. So you're going to see the gallbladder wall, then that bright linear echo, and then shadow behind it. Gangrenous gallbladder is a serious and painful complication of acute cholecystitis that can lead to perforation of the gallbladder wall. It occurs usually after a prolonged infection, which causes the gallbladder to undergo necrosis. The wall can get very thick and edematous, and you may see focal areas of exudate, hemorrhage, or necrosis. So this means that the wall gets little focal perforations in it through which the pus from the gangrene from the gangrenous gallbladder can exude into the surrounding tissue. You can also bleed through those wall perforations, and that necrosis, right, that's the death of the tissue, so that's also going to have exudate associated with it as well. Ulcerations and perforations result in pericholecystic abscesses or peritonitis. So you may see infection and inflammation of the peritoneum with gangrenous gallbladder. And in nearly all of these patients, we're going to see gallstones or fine gravel, which is just very small stones that have been they look just like gravel. They're sort of ground up. So that's going to occur in about 80 to 95% of the patients. You recall we looked a few slides back at a gangrenous gallbladder when we were looking at examples of cholecystitis. The common echo feature for gangrene is the presence of diffuse medium to coarse echogenic densities that fill the gallbladder lumen in the absence of a bile duct obstruction. So you can't find any stones or anything obstructing the bile duct, but you have this ugly edematous filled gallbladder. The material is going to have the following characteristics. It probably isn't going to shadow. It's not going to be gravity dependent, and it's not going to show a layering effect. It's going to appear to fill the gallbladder lumen. You'll recall we said acalculous cholecystitis is acute inflammation of the gallbladder in the absence of cholelithiasis. So you're going to have a thickened edematous gallbladder wall. You may see pericholecystic fluid, and if you put color Doppler on this, the wall is going to be hyperemic. Now, chronic cholecystitis is a little different. Typically, these patients have had a number of attacks of acute cholecystitis, and what you get is shrinking and scarring of the gallbladder. This is the most common form of gallbladder inflammation, and you're going to get, like I said, that fibrosis of the gallbladder wall. So these patients typically won't have the acute and severe pain of acute cholecystitis. They're going to have some tenderness. They may have some transient right upper quadrant pain. It's going to present almost like biliary colic. And oftentimes we will see stones in these patients. Torsion is a rare condition. We see it primarily in older women, and it is associated with a mobile gallbladder that has a long suspensory mesentery. So the gallbladder is attached to the mesentery of the abdomen, and that mesentery can stretch as the patient ages. And just like any other connective tissue, it can start to stretch out. When that happens, the gallbladder can then twist on that mesentery. And if it becomes twisted more than 180 degrees, the blood supply can get interrupted. You can also get obstruction of the cystic duct because of the twisting. So then you can see obstruction and loss of blood supply becomes necrosis, and pretty soon you have a possibility for gangrene. The symptoms are going to be typical of acute cholecystitis, and you're going to see a gallbladder that is massively inflamed and distended. It may measure greater than 10 centimeters in length. And this is a surgical intervention necessity. Cholelithiasis is the most common disease of the gallbladder. It's the one you're going to see most often, and it is the presence of stones. There can be one or there can be many. If one, can be any size. If there's a lot, they tend to be smaller, and tiny equals dangerous. If it's a single large stone, it's just going to kind of rattle around in that gallbladder. When the gallbladder squeezes, it's probably not going to get stuck because it's too big to get down to the neck. But when you have multiple tiny stones, you're more likely to get one lodged in the neck or in the cystic duct or common bile duct. Patients are going to often, this is actually untrue. So this next one says patients often fall under the category of the 5 Fs. Fat, female, over 40, fertile, meaning not yet through menopause, and fair, meaning we saw it more often in patients who were blonde or redhead and had pale skin. However, the standard American diet, and we've sort of thrown these things out of the window because we are seeing cholelithiasis in all kinds of patients because of our standard American diet. We've seen it in patients as young as their early 20s, even some teenagers, and the rest of those actually also no longer apply. Obesity is a risk factor, as is diabetic. Again, pregnancy, right? We decided pregnancy was rough on a lot of things. Oral contraceptive use, hemolytic diseases, even weight loss. So if you start a diet and you're losing weight and you're feeling great because you're getting healthy, you might still get gallstones. Also, total parenteral nutrition when they're being fed through IV. And then you want to watch, this is where you're most often going to see that Wes sign that we talked about, wall, echo, shadow. Remember, it's going to be the gallbladder wall, then an echogenic, a bright linear echo, and then shadowing behind that. So here's just a couple different appearances of cholelithiasis. In that first one there, let me get the laser pointer. You can see that we've got some tumefactive sludge as well, and then we've got these bright foci here with shadowing. See that shadowing behind them? Those are the stones down there. So this one's got a little bit of everything. We've got some fluid up here representing normal bile. We've got the tumefactive sludge, and then we got the stones. Over here we have a solitary stone. Notice that it has a calcified bright echo, and then it shadows behind it. Now this is an example of the Wes sign. You can see that with Wes sign it can be very hard to find the gallbladder. So if you're new or inexperienced, the first time you see this, you're going to be struggling because you're going to think you can't find the gallbladder. In reality, you're looking at it. So what we have is the gallbladder wall, a bright linear echo, and then complete shadowing out behind it. Okay, here you can see that gallbladder wall, and then you can see that bright linear echo. Okay, porcelain gallbladder. This is a rare occurrence. It's defined as calcium incrustation of the gallbladder wall. So the gallbladder wall itself becomes calcified or porcelain. Oftentimes, the majority of patients with porcelain gallbladder are going to have gallstones, and we see it most often in older female patients. It can be mistaken for the West sign. So that would be your differential. Is it a packed bag full of stones, or is it a porcelain gallbladder? And try to take it from several different angles. See if you can see any calcified wall at the back as well as at the front, because that may be the telling sign for is it packed bag or is it porcelain gallbladder. Now it's important to know this because porcelain gallbladder is an indicator or a precursor sometimes for gallbladder cancer. So if we see porcelain gallbladder, we want to be, these patients are at a high risk for gallbladder cancer. So we want to bring this to the attention of the radiologist or the ordering physician. Okay, hyperplastic cholecystosis is different than cholecystitis. Cystitis is an inflammation of the gallbladder. Cholecystosis is a disease of the gallbladder, and it's represented by a variety of degenerative and then proliferative changes of the gallbladder. So the gallbladder degenerates and then tries to regenerate. The characteristics of this are going to be hyperconcentration of the bile, hyperexcitability, so any little thing will make the gallbladder contract, and then hyperexcretion. It's going to contract forcefully. There are two types, cholesterolosis and adenomyomatosis. Cholesterolosis is small cholesterol deposits in the mucosa of the gallbladder. It's called strawberry gallbladder because it starts to take on the pitted appearance of a strawberry. And you can get little polyps on the inside of the gallbladder that you may be able to see as well. Adenomyomatosis is also similar in that you're going to get little papillomas along the lumen, little elevations into the lumen of the gallbladder. Typically, adenomyomatosis, you're going to see comet tail artifact with those coming off of those little papillomas. Occasionally with cholesterolosis, the polyps in the lumen of the gallbladder may also cause that comet tail artifact. It's going to be more common with adenomyomatosis than cholesterolosis, but they are differentials for each other. And these are just a couple of varying types of appearances that you will see on sonogram. This first one over here, let me put the laser pointer on. There we go. This is going to be cholesterolosis. Okay, we get the little invaginations and folds. We see there's a little polyp there. We got some sludge in there as well. Okay, now over here we have adenomyomatosis, and you can see the little ring down artifact coming off of these tiny little papillomas. Okay, I'm sorry, I said this was a polyp. This is actually a stone. The last gallbladder pathology we're going to talk about is gallbladder carcinoma. This is very rare, but it's almost 100% fatal because it's rapidly progressing and we often don't catch it until it's at an advanced stage. It's going to be associated with cholelithiasis. So many of our patients who have gallbladder carcinoma are going to have had gallstones. It's twice as common as cancer of the bile ducts. We see it more often in women, especially those over the age of 60. And usually it's going to start in the body of the gallbladder. But again, because it is very aggressive and rapidly progressing, it will often invade the adjacent liver parenchyma as well. So you can end up with metastases into the liver. All right, we're going to move on to all of the things that can go wrong with the biliary tree itself. So with the ducts, we can see choledochal cysts, Caroli's disease, which is a type of choledochal cyst. We can see dilated biliary ducts, biliary obstruction, just as you can get a stone in the gallbladder. Those stones can move and become obstructed in the ductal system. Choledocholithiasis, which is stones in the duct. Hemobilia, pneumobilia, cholangitis, ascariasis, which we've talked about before, and then cholangiocarcinoma and metastases. We're going to start with choledochal cysts. Choledochal cysts are rare. They're more likely to occur in women than in men, and we're more likely to see them in infants and children than we are in adults. They can be associated with gallstones, with pancreatitis, or with cirrhosis. They can also be congenital or acquired. The symptoms include pain, fever, jaundice, abdominal mass. Most of them are going to be congenital, which is why we see them in infants and children more than we do adults. And there are 5 different types. Type 1, which is down in the lower corner here, this is type 1. This is the most common type, along with 4A. And this is a fusiform dilation of the common bile duct. So it's going to be extrahepatic. So when we're looking at these diagrams here, what you want to notice is this is your left and your right hepatic ducts coming together to form the hepatic duct. And then you have the common bile duct. And then this line here is representing the pancreatic duct. Okay, so type 2 is a true diverticular outpouching of the bile ducts. So type 1 is fusiform, meaning it's going to be sort of like an aneurysm in that it expands equally on all sides. The outpouching, the diverticular outpouching, tends to be more like a saccular aneurysm if we're going to compare it to like a AAA. Okay, type 3 is dilation of the distal mural portion of the common bile duct protruding into the duodenum. So it's a choledococele. So what happens is here where the pancreatic duct and the common bile duct come together and enter the sphincter of Oddi through the ampulla of Vater, the ampulla of Vater through the sphincter of Oddi, right there is where you're going to see that dilation of the common bile duct. So it actually will protrude through that sphincter of Oddi and into the duodenum. Type 4 is when you have more than one. You have multifocal dilations, intrahepatic and extrahepatic. So type 4A, we're going to see intrahepatic and extrahepatic. Type 4B is confined to the extrahepatic system. So type 4A, which is here, remember we said it was the most common secondary to type 1. We're going to have that fusiform dilation extrahepatically, and then notice inside the liver we've got dilations there as well. Type 4B, they all happen outside the liver. Okay, and then type 5 is up here. It's called Caroli's disease, and it gets its own slide. Sonographically, you're going to see true cysts in the right upper quadrant. You may see a communication with the biliary system, or you may not be able to follow the cysts to the biliary system. The cyst can be large enough that you just might be like, is that a hepatic cyst or is it a choledochal cyst? I'm not entirely sure. It can have sludge, stones, or it can have solid neoplasm in it, which would then be ductal carcinoma. And as I said, if it's large, it can be hard to distinguish the connection to the bile duct. Here's just a number of examples of ways that choledochal cysts can appear. Notice that it's hard to say, oh yeah, that's a bile duct, right? Or even here, we got the gallbladder over here, and we got this big choledochal cyst down here. So typically, they're just going to be cystic structures that you're going to see in there. They may not be perfectly round. They can have different serpentine shapes, which will help you sort of decide that it's probably common bile duct or choledochal cyst versus hepatic cyst. Tell you that Caroli's disease gets its own slide, and here it is. So Caroli's disease is a rare, inherited, autosomal recessive congenital abnormality. So they are born with it, and it is attached to a recessive gene, so both parents must be carriers. It's going to be communicating cavernous ectasia of the intrahepatic ducts, characterized by congenital, segmental, saccular, cystic dilation of the major intrahepatic bile ducts. What that means is congenital, they were born with it. Segmental, it's happening in different sections of the ducts. Saccular, they're going to be those sort of little diverticular outpouchings rather than fusiform. And then of the major bile ducts, so the left one and the right one. Okay, it's going to happen on the major hepatic ducts. We see it in young adult and pediatric populations, and it can be associated with renal disease or congenital hepatic fibrosis. So oftentimes Caroli's disease does not stand alone. Symptoms are going to include recurrent upper abdominal pain, biliary stasis, ductal stones, cholangitis, and hepatic fibrosis, because we're getting that obstruction intrahepatically. The liver is going to try to do that. It's going to have that progressive, like parts of it being damaged and subsequent regeneration and repair that results in fibrosis of the liver. If you may see cystic disease of the kidney with Caroli's disease, that's the medullary sponge kidney. We're going to talk about that more next week. And patients can experience renal failure. There's two different types of Caroli's disease. You can have the simple classic form or the more common form with periportal hepatic fibrosis. It's going to appear on ultrasound as multiple cystic areas are structures in the area of the ductal system that converge toward the porta hepatis. So they're going to seem to cluster and point to the porta hepatis. They can be localized or diffusely scattered, and they're typically going to communicate with the bile ducts. You may see ectasia of the extrahepatic and the common bile ducts as well, and it can have a beaded or a string of pearl appearance. There can be calculi or sludge, and on many of these intrahepatic intraductal cysts, you're going to see the classic central dot sign. It'll be a small circular anechoic cyst with a single echogenic focus in the center. The central dot will often contain blood flow, and that's what we're seeing down here. So here's the picture without color Doppler. You can see the cystic structure, and then that echogenic central dot, which is right underneath my laser pointer, so when I move it, you'll see that. There we go. And then when we put color Doppler on it, we can see blood flow in that central dot. Now up here we've got a number of cystic structures, all seeming to sort of like cluster or converge around that porta hepatis. Next up is dilated biliary ducts. So if you see dilated biliary ducts, any duct, a hepatic duct of 5 millimeters is going to be borderline. 6 millimeters means you need to be looking around a little bit more. So you may need to measure the hepatic ducts. The common bile duct is going to have an internal diameter slightly greater than that of the hepatic ducts. And remember, the common bile duct is going to increase with every decade of age. So common bile ducts of greater than 6 millimeters is considered borderline. You want to take into account have they had a cholecystectomy and what is their age. If it's greater than 10 millimeters, it is definitely dilated. The patients can still have a normal hepatic duct and still have distal obstruction. And obstruction is going to be the most common cause for dilated ducts. The most common cause for obstruction is the presence of a tumor or thrombus within the ductal system. And you can see this either intrahepatic or extrahepatic. Your job is to localize the level and the cause of the obstruction. Now, when we're talking about this tumor and that, we're going to be talking about extrinsic, but also sometimes intrinsic obstruction. So primary areas for extrahepatic obstruction are going to be intrapancreatic. This is caused by pancreatic cancer, choledocholithiasis, or chronic pancreatitis with stricture. They can be suprapancreatic, meaning above the pancreas, so between the pancreas and the porta hepatis. Remember, the portal vein runs from the pancreas vertically and oblique up to the porta hepatis. So suprapancreatic is going to be above the pancreas. It can be malignancy or it can be adenopathy. Porta hepatic is going to be at the level of the porta hepatis, and usually this is going to be due to neoplasm, but uncommonly it can also be caused by Merizi's syndrome. Merizi's syndrome is an uncommon cause for extrahepatic biliary obstruction, and it's a result of an impacted stone in the cystic duct, which creates extrinsic mechanical compression of the common hepatic duct. So it gets stuck in the stone gets stuck in the cystic duct, and then because of that, it puts pressure on and compresses the common hepatic duct. Choledocholithiasis is going to be stones in the duct. There's two different forms. The primary form is de novo formation of stones in the bile duct, and the secondary form is migration from the gallbladder. So we see the secondary form when there are stones in the gallbladder that are then passed through the neck of the gallbladder and make it through the cystic duct and then end up in the common bile duct. The primary form is de novo formation in the bile duct itself. That means that even if your gallbladder has been removed, you can still make stones. Your ducts can make stones. You're going to run into sonographers out there who get an order for a biliary ultrasound or a right upper quadrant ultrasound for right upper quadrant pain, check for stones, and they'll be upset because the patient's already had a cholecystectomy. That doesn't mean they can't make stones. They can still make stones in their ducts. Okay, so what it's going to look like are dilated ducts with echogenic focus that may or may not have shadowing. Sometimes they're too small to shadow. The differentials, or the other things that it might be, are calcifications in the hepatic artery, pancreatic head, or air or gas in the duodenum, or intrabiliary gas. Hemobilia and pneumobilia are going to be blood and or air in the biliary system. Hemobilia is blood in the biliary tree, and causes for this are going to be trauma, cholangitis, cholelithiasis, because those stones passing through there can irritate the wall, cholecystitis, vascular malformations, malignancies, and biopsies can cause hemobilia. Anytime we're taking tissue, we're creating bleeding. You want to look for fluid with low-level internal echoes or mobile echogenic clots that can extend into the gallbladder. Pneumobilia, this is air within the biliary tree, and the causes are going to again be trauma, biliary interventions like ERCPs, biliary enteric anastomoses. So a connection has formed between the intestinal tract and the biliary tract. Common bile duct stents and emphysematous cholecystitis will also bring about pneumobilia. You want to look for bright echogenic linear structures that follow the portal triads. You're going to see posterior dirty shadowing. You may see reverb or comet tail artifact, and you may even see movement of tiny air bubbles when the patient changes position. It can look like the little bubbles you get along the side of your glass when you're drinking cola. Cholangitis is going to be an inflammation of the bile ducts. The wall is going to become very thickened. Cholangitis is a medical emergency. So increasing pressure in the biliary tree with pus accumulation, we have to get in there and decompress that. So it is a medical emergency. There are different types of cholangitis: oriental sclerosing cholangitis, AIDS cholangitis, and acute obstructive suppurative cholangitis. All of them are serious complications, so you want to definitely bring these to the attention of the radiologist if you see anything that might be suggestive of it. Symptoms are going to include general malaise, fever, right upper quadrant pain, and jaundice. We talked briefly about ascariasis when we discussed the liver. This is a disease caused by a parasitic roundworm, and it's a fecal-oral transmission. So it ends up in the feces of other animals, and then either gets into this, somehow gets into the alimentary tract, right, through oral cavity. And the worms can get very long. They can get 20 to 30 centimeters long and up to 6 centimeters in diameter. They're going to grow in the small bowel before entering the biliary tree through the ampulla of Vater, and they can cause acute biliary obstruction. Clinically, the patient can be asymptomatic, meaning they don't even notice that they're there until they start to cause problems. They can have biliary colic, which is one of the problems. Pancreatitis, they can irritate that pancreas and inflame it. Or they may have symptoms similar to cholelithiasis or acute cholecystitis. You will actually be able to see the worms in the gallbladder. You may also see a mobile tubular parallel structure in the duct if they're still stuck in the duct of in the common bile duct. Okay, hang in there with me. We're almost done. Cholangiocarcinoma, this is going to be cancer of the bile duct system. It's rare that it's going to it's rare, and it originates in the bile ducts. The frequency is going to increase with age. So your primary risk factor is going to be increasing age. And if you had primary sclerosing cholangitis, which we see more in Asian populations, that's why it's called Oriental sclerosing cholangitis, that is a risk factor, along with cirrhosis, and hepatitis C is also a risk factor. So the same things that cause liver cancer can cause bile duct cancer. The classification is going to be based on where it's at. Is it intrahepatic? Is it hilar? Or is it distal? And then in top of that, there's also subtypes. It's going to divide it into a subtype of either sclerosing, nodular, or papillary. The prognosis for all cholangiocarcinomas is not great. So intrahepatic cholangiocarcinoma, this is going to be the least common location, but it's the second most common primary malignancy of the liver. And the primary risk factors are going to be cirrhosis and hepatitis C. Again, very poor prognosis, and the sonographic appearance is variable. But what you're going to see oftentimes is going to be dilated ducts with hepatic involvement. So if we look, here's those dilated ducts, and then right here, it's very hard to make out, especially if you're not knowing what you're looking at, is hepatic involvement. There's a duct here, there's an obliterated duct over here, and that carcinoma has actually started to invade the liver tissue. Okay, hilar cholangiocarcinoma is also known as Klatskin's tumor. You do want to know what Klatskin's tumor is. It shows up on a lot of tests. Okay. It's going to occur at the bifurcation of the common hepatic duct, and you will see involvement of both the central left and right ducts. So the central left duct and the right duct will both be involved. The most common sonographic feature is going to be isolated intrahepatic ductal dilation. And what you're going to see is that the right duct and the left duct do not appear to come together. Right? The right duct and the left duct are going to come together and form the common hepatic duct. And when you have a Klatskin's tumor, the primary sonographic appearance is that those ducts do not communicate with each other. There's a non-union. The tumor can extend outside of the ducts to involve the adjacent portal vein and arteries, and chronic obstruction is going to lead to atrophy of the involved lobe of the liver. Again, this is a very aggressive, typically fatal cancer. Most patients are going to die within a year of diagnosis. And here is that typical non-union of the left and right ducts that we talked about. You've got ductal duct coming this way, you got duct coming this way, and they do not appear to communicate and come together. They're also dilated because of the tumor. And then here's your tumor right here, sitting between those ducts. There's the tumor right there, okay? That is a Klatskin's tumor. Distal cholangiocarcinoma is going to happen past that hilar, that connection of the right and left, and so it's going to happen lower on the hepatic duct or in the common bile duct. It's going to be hard sometimes to distinguish it from hilar cholangiocarcinoma, but progressive jaundice is going to be seen in the majority of the patients. They're going to start to turn yellow. The tumor mass can be different types. It can be sclerosing or it can be polypoid, and you're going to see it spread in the superior ductal system and the extrahepatic area. You want to look at those very carefully and see if you can find any tumor spread. So it can, again, invade the surrounding tissues and organs like the liver and the pancreatic head. It can also get into the lymph nodes, and the sclerosing tumor is going to be nodular with focal irregular ductal constriction, and you're going to see wall thickening. It's going to have a hypoechoic and a hypovascular appearance with poorly defined margins. There is a tumor in this picture. It's right here. Finally, we have to talk about metastases. Now, the most common tumor sites that can metastasize and spread to the biliary system are going to be breast, colon, or melanoma cancers. It can affect the intrahepatic and the extrahepatic ductal systems. And on sonography, the appearance of the metastases is going to be similar to that of cholangiocarcinoma. So any of those sonographic things that we talked about, the dilated ducts, the non-union of the ducts, those sorts of things can be caused by metastases as well. So you may see a grossly enlarged cystic duct with solid papillary tumor in it, or you may see smaller dilations of the ducts where the ducts should be anechoic, but they have debris in them, which is what this first one up here is showing. You can see the arrow is pointing to a smaller dilated duct that should be anechoic but seems to be filled in and is closer to the same echogenicity as the liver itself. And then down here, we've got that large cystic dilation with a solid carcinoma inside of it. That concludes our discussion on gallbladder and biliary system pathology.